Dr. Jeffrey Miller is director at the Masonic Cancer Center Cell Therapy Core Laboratory at the University of Minnesota and is willing to discuss the presentation of Dr. Kaseman. Advanced patient age is not associated with prohibitive toxicities resulting from non-myeloablative haploidentical transplantation followed by high-dose cyclophosphamide. Moreover, the clinical outcomes were comparable to those of HLA-matched allogeneic HSCT. These results indicate that NMA haploHSCT can be an attractive alternative to treat older people. Based on the data of Dr. Kaseman, do you envisage an increase in the application of NMA haploHSCT plus cyclophosphamide for elderly patients in the near future?
So I think that remember, this whole meeting is full of transplant applications, and I think the paper that we're discussing here today is yet another paper saying that we need to expand access of transplantation. I'm a transplanter for greater than 20 years in the field, and this is yet another example of an alternative donor transplant that is going to expand the access to patients with hematologic malignancies requiring potentially curative therapy. I think the important things that are being highlighted here is that we could do this safely. You know, we've had this bias in the transplant field that if you're 65, if you're 70, that you can't withstand the intensity of the transplant. And there are several different examples, this being one of them, about how we have novel approaches that can be tolerable to relatively healthy people other than their underlying cancer at older age. So I think it's an important aspect. People are definitely expanding the use of these type of transplants. And this type of transplant is one graft source from a haploidentical donor. The same thing is going on with umbilical cord blood transplant with these mini preparative regimens. And I think what we're all starting to understand is we should not prohibit older adults. When you look at acute myeloid leukemia, the peak incidence is over age 50. So this is exactly the population that we need to treat. I think they've nicely shown in their study that older age individuals can tolerate it. You know, different centers do different graft sources. This is becoming very popular because it's easy, it's not very toxic. There are other venues like cord blood that are being tested as well for those patients who do not have an HLA-matched sibling donor. So it's really expanding the access for the use of transplant in older individuals with leukemias who are typically the target population here.
Okay, and do you foresee a change in the age limit for NMA haploHSCT?
I think for transplant in general, and remember this is one paper, this meeting is full of thousands of abstracts in different approaches for transplant. I think the take-home message, and remember, I am supporting the American Society of Hematology, putting this into perspective of the transplant field. And this is, again, another good example about how the field is gradually been moving up the age for transplant because we can do it safely. And this is really important. You know, when you have curative therapy, you do not want to limit it to being under age 55. As we're all getting a little bit older, we want to make sure that we can still have the opportunity for curative therapy. So, you know, we've had proof of concept. We know transplants can cure hematologic malignancies. What we have been working on, I think, for the past decade is how to do it with less toxicity, making it available to more patients. So there's no question. At our center, I'm at the University of Minnesota, across the country, everybody's inching up the age. The question is, what is the upper age limit? At our center, it's currently 75. I think that as part of this paper presented, they've been trying to work on what are called morbidity scores to look at the health of the individual rather than an absolute age, and it's very difficult. I mean, there are people for which transplant is still too intense to tolerate. But to answer your question, across the country and across the world, transplant ages are going up. Partly, you know, the main innovation here is not necessarily with this paper, is the reduced intensity conditioning. Transplant 15 years ago was all full prep transplants, and we know those toxicities. With reduced intensity conditioning, the morbidity and mortality is dropped by half. There is a downside to reduced intensity conditioning, is that relapse rates are higher because there's less less chemotherapy directed against the cancer. And some of the other things that have been highlighted in our session about where the field is moving is we're now starting to look at immunotherapeutic approaches to take care of the relapse problem when you do these reduced intensity transplants. So it's a complex mix. It's all about risk and benefit of the underlying malignancy and how to best mediate a cure but still have somebody healthy enough to have an absolutely normal quality of life. That's certainly the goal.
And what would you expect regarding the development of graft versus host in the long term?
Yes, so graft versus host disease, when the donor graft attacks the patient's body, continues to be an ongoing problem. I think one of the things that they nicely demonstrate with their approach in the post-transplant Cytoxan is that they can mediate the immunologic response, and they do not see any worse graft versus host disease, which continues to be a source of morbidity and mortality. Now, we do like to see a little bit of graft versus host disease because it correlates with this graft versus leukemia response, which is preventing relapse in the long term. So there's no perfect balance. If you take away all graft versus host disease, relapse rates are going to go up. And again, what we need is a rheostat to dial this up and down effectively. You want enough immunologic reactivity not to hurt the patient. But once it gets bad, it can be very bad, and that continues to be the challenge. We need that rheostat. We don't have it yet, but we're looking for it.
Okay. Thank you very much for this discussion.
Thank you.